Good afternoon, everybody. I'm Dr. Theodore Friedman. I'll be presenting today on our exciting findings on comparing medical group versus individualized dietitian-led visits as a way to approach the obesity epidemic in an inner city setting. My co-authors are Petra Duran, Magda Shaheen, Martin L. Lee, Raven Bean, Candice Lau, Michelle Nemeth, Francisco E. Ramirez, and Theodore C. Friedman, where work is done at Charles R. University and LA County Department of Health Services, Martin Luther King Outpatient Center. We're funded by the Access Grant, award number U54, MD 007598, with the principal investigator, Dr. Jay Vagama. The background of our study is the Los Angeles County Department of Health Services treats over 600,000 patients a year, and at least 200,000 of these patients are obese with obesity-related diseases. Due to the large patient volume, innovative high volume, high quality, low cost sustainable programs are needed to address the obesity epidemic. Medical group visits have been used to treat chronic diseases, but their efficacy in obesity has not been well studied, especially compared to individualized dietitian-led visits, which I would say is a standard of care in most safety net settings. Our purpose in this study was to compare a medical group visit approach with a individualized dietitian-led approach in a randomized trial of 12 months in duration. Our methods include that we had 167 adults, ages 22 to 73, of which 84% of them were females, 60.5% were Hispanic, and 34.9% were non-Hispanic Blacks. They were recruited from Los Angeles County Department of Health Service, Martin Luther King Outpatient Obesity Clinic. They were randomized in a 3-to-1 ratio to the medical group with an N of 124 and to the dietitian-led visit group with an N of 43. The data was analyzed for changes from baseline in weight, BMI, hemoglobin A1C, total cholesterol, HDL, and triglycerides, and food intake from the total sample and between groups using the Wilcoxon sign rank or median test, as well as repeated measure analysis of variance. Table 1 shows the effect of weight, the baseline weight median, because it was skewed, so we did medians. The baseline weight was 259. The follow-up weight was 245. This is for the total group. The p-value was highly significant. The BMI went from 46 to 43.5. Hemoglobin A1C went from 6.4 to 6.2. Cholesterol went from 170 to 170.5. And although this doesn't look significant because of the way the medians were, this was significant. The HDL went from 44 to 47.1, 47.0, which was also significant. The LDL was unchanged. Triglycerides were significantly dropped from 144 to 122. Then we did this healthy eating index. The number of calories decreased from 1404 to 1043 with a highly significant decrease in calories. The total protein was also significantly decreased, as well as the total fat. The mean weight loss for the dietitian group was 6.6 pounds with an interquartile ratio of 10.9 and 7.5 pounds with an IQR of 19.8 for the medical group. This was non-significant. The effects of the by ethnicity, the weight change was a 6.3 pound loss in the dietitian group. In the Hispanics, while in the African Americans, it was 6.6 pounds. In the medical group, it was weight loss of 7 pounds. In the Hispanic group, 8.1 pounds. In the African American group, and 5.2 pounds in the white group. This was not significantly different, but shows that in all ethnicities, the weight group was quite impressive. This shows the hemoglobin A1C. The hemoglobin A1C in the dietitian group was unchanged at 6.9. However, the medical group, it went from 7.0 to 6.5. This was highly significant with a p-value of 0.009. And the number of visits in the dietitian-led group was 19.1 versus 11.5 in the medical group. This was also significant. And the repeated measure of ANOVAs, the cholesterol went down significantly, the LDL went down significantly, the others were insignificantly affected. Our conclusions were that a significant number of patients in both groups lost more than 5% of their weight. Results show that no significant difference between the groups in terms of weight. The medical group had a significant improvement in the lipid profile and hemoglobin A1C levels compared to the dietitian-led group. The healthy eating index improved for calories, protein, and fat in both groups. And our conclusions are that the improvements in the medical group are more impressive and cost-effective since they were occurred at less number of visits. We will be analyzing the change in weight and BMI in the control group with no intervention. This is our third group. And we'll be also examining coronary calcium scores and perivascular fat measurements in the heart in the medical group visit approach, the individualized dietitian-led group, and the control group. We are funded by the NIH Access Grant U54MD007598. Thank you very much.